Hi, everyone. Thanks so much for joining us today. I am really excited to introduce Dr. Bob Hendren and this much anticipated talk, giving us a child and adolescent psychopharmacology overview. Dr. Hendren is a professor of psychiatry and behavioral science at the Division of Child and Adolescent Psychiatry at UCSF. He is co-director of the UCSF Dyslexia Center and the director in the program for research on neurodevelopmental and translational outcomes, or PRONTO. He is also an attending psychiatrist for the UCSF STAR Center for ASD, autism spectrum disorders and neurodevelopmental disorders. Dr. Hendren is past president of the American Academy of Child and Adolescent Psychiatry, serving in that role from 2007 to 2009. He has published over 150 scientific papers and 5 books, and has been listed in the Best Doctors in America each year since it was first published in 1996. From 2001 to 2009, he was professor of psychiatry and executive director and chair at the UC Davis Mind Institute. His current areas of research and publication are translational interventional outcomes, including clinical psychopharmacology, nutraceutical and nutritional trials using biomarkers, and in order to enhance resilience in neurodevelopmental disorders. With that, I will turn it over to Dr. Hendren. Thank you.
Okay, well, thanks for the nice introduction, Petra. It's always nice to work with you. I appreciate getting to know you, Joan, and I'm looking forward, although I can't see you and we don't get to all be together, to have a way of getting to know all of you here. I've learned a bit about your practice and your interest in this. And so I appreciate this opportunity to be able to do what's going to be a very quick overview of child and adolescent psychopharmacology. I have a little over 40 slides. We have about 50 minutes, a little less than 50 minutes. So I'll go through the slides fairly quickly. I think you have access to these slides and you can get them. And for some of the areas that I'm talking about, you may feel very comfortable and know a fair amount. And for some of the areas, you may feel like you'd like to spend longer. And I've put resources for where you can find more. And I understand that you also can ask questions and that those questions will be passed on to me, which I'll answer as well. So the next slide talks about my disclosures. The grants that I do are largely of nutraceuticals, integrative medicine type approaches. We're not going to talk about those today. I'm on advisory boards for a number of companies. The only one that has anything to do with what we're going to talk about is Janssen, which makes Risperdal, but I'm not going to promote it. And then I get honorarium and royalties from books. Next slide, please. So we all know, or it appears, that the prevalence of psychiatric disorders in children and adolescents is a fairly common thing. 10% of kids have a medication-responsive psychiatric disorder, that 12% have a diagnosable DSM-5 mental disorder before age 18, and 3% of children have a serious emotional disorder, which would warrant, in most cases, a medication treatment. Next slide. And the next things to come up. This increase in the use of psychotropic medications has been due to a combination of good reasons and maybe some that aren't so good. So the good ones are efforts to educate the public about kids, scientific advances, evidence that early treatment improves long-term outcome. Next. And that we, the things that are not so good are that people want a quick fix. They want to find a medicine that'll make things better right away. And there's been a greater acceptance of using medications in that way. There's also been a change in healthcare delivery that pushes for medication use to somehow shorten the duration of the acuteness or to avoid a more restrictive kind of treatment like residential or inpatient. So there are some reasons that we often wind up kind of fighting with, saying, wait, I'm not ready to increase that dose right now or to change to a stronger medications. I'd like to try other things. So we get the pressures going both ways. Next. To give you, I'm going to kind of go through this like a table of contents. I'm going to list, first the table, or like a book, list the table of contents, then give a little bit of a synopsis, and then go through in a little more detail some of the talks. But if you're thinking about psychopharmacology for children and adolescents, there's 6 categories that you can think about. So when the child comes in and you're saying, what do I do now? Well, you can start by saying, well, could this person use a stimulant or an adrenergic agonist or an antidepressant? And we're going to talk more about all of these. Next slide. Or next, could we talk about neuroleptics or mood stabilizers or minor tranquilizers, which we use rarely and for short periods of time, not for long periods of time. There's a reference here to an article in Current Problems in Pediatric Adolescent Healthcare from 2017. That's a nice review of this, written by some good doctors that I think could give you a good overview if you wanted to read something. Next slide. So now we drill down the next. We're going to go through stimulants, and then we're going to go through each of the categories. So for stimulants and non-stimulants, there are main groups. In stimulants, it's methylphenidate or dextroamphetamine. And everything else that's listed there has as its basis one of the others of those, but the difference is in the method of release or the duration of action. So it's not like every one of these names means, oh God, I've got to learn another stimulant medication. You can say, well, is it methylphenidate or is it dextroamphetamine? And we'll go through those in more detail. Or you can say, I don't want to use a stimulant, or I've used a stimulant and I've had side effects. Are there other choices of non-stimulants? So there's atomoxetine. There's this newly released medication that's similar to atomoxetine in that they're both antidepressants, but they work on a little different neurotransmitter systems. That's called Quilbri or viloxazine. And then there's another antidepressant, but works differently, Bupropion or Wellbutrin. Atomoxetine and viloxazine both work a little more on the noradrenergic system, although viloxazine also works on the dopaminergic system, and bupropion works primarily on the dopaminergic system, but differently than the way stimulant medications do, which also work on the dopamine system. They're not exactly the same, but which should lead to caution about using the two of them together. So, because you're pushing on the same neurotransmitter. So, next slide. Adrenergic stimulating agents is the next category, and they're clonidine and guanfacine. And I'll bet many of you use them for other reasons, although you may use them for ADHD, but they're commonly used even in young kids for sleep, for anxiety, but also to treat blood pressure problems or other things as well. So using them means you have to be concerned about blood pressure or heart rate. It mainly works on blood pressure by slowing the heart rate. And we'll talk a little more in detail about the different kinds in each category, but Catapress and Capve are the long acting. Catapress is the short acting, Capve is the longer acting. And for guanfacine, 10x is about 12 hours, and Inteneve, 8 to 12. And Inteneve is more like, they say 24 hours, but if you only need to give it once a day. Next slide. So antidepressants, there's a large list of those, and we're going to go through them in a little more detail. But the majority of studies would say that if you're treating anxiety and depression in adolescents, that it's SSRIs are generally your best place to start. And the SSRIs that we use the most often are fluoxetine, paroxetine, and escitalopram. Probably fluoxetine works the best because it has a little broader spectrum than just serotonin, but it has a troubling side effect called activation for some kids, where they feel an inner restlessness, like they're going to jump out of their skin. But it doesn't happen often. And it happens more often, though, with kids with neurodevelopmental disorders. So for kids that don't have that, straightforward depression, that's usually not a concern. But it appears that Zoloft and Lexapro have that a little bit less. So that can become your next choice. And again, we're going to go through that more. Studies that have looked at treating depression or anxiety say start with an SSRI. If one doesn't work, try another. If that doesn't work, then try an SNRI, a selective norepinephrine reuptake inhibitor. And those are the ones here like duloxetine, venlafaxine, desvenlafaxine. I got those mixed up because Pristique is the trade name. So generally try one of the SNRIs second. And then some people go on to thinking about Wellbutrin, Bupropion. And then the rest of the list are fairly new medications. Trazodone, mirtazapine are sometimes used for sleep in kids, but not usually at their regular dose. And the others are relatively new. So we don't have as many studies to feel confident in when we're using these meds for kids. Next slide, please. Atypical neuroleptics. We're talking about symptoms like social awkwardness, inappropriateness, withdrawal, tics, OCD, disorganization, hallucinations, delusions. So it's not just for psychosis, but it's something that we use like for kids with autism for irritability and for impulsivity. The ones we use most commonly are risperidone and aripiprazole. For autism, those two medications have an indication for treating irritability in autism. Others that we use are olanzapine, quetiapine. Ziprasidone seems to not have weight gain, and asenapine on the other, or I'm sorry, where did it go? Geodone and Latuda on the other side are two that seem to not have weight gain. But both of them cause a kind of that inner restlessness, that activation that I described. And some kids just don't do well on it. Some adults don't either. So I consider them for people that have put on a lot of weight, but I use them cautiously, watching for that activation that might happen. I'm going to repeat some of the things that I've said. So if it seems like I'm going way too fast, I hope that by repeating it, that it'll stick. But if not, then I'm happy to have you bring it up as we get towards the end. Next slide. Mood stabilizers are generally meds that you're using to control seizures. So Depakote, Tegretol. But the most common that we use as a mood stabilizer for kids in psychiatry are lithium and valproic acid. Occasionally, as a milder kind of agent, we consider gabapentin, topiramate, and sometimes pregabalin, especially if there's a lot of anxiety. As you might know, Lyrica has become a controlled substance now. So like benzodiazepines, you can get a 3-month supply, but you still need to use your going through the Cures website and get permission to do it, because people have abused it and because maybe of its anti-anxiety effects. Next slide, please. And then finally, that other category that I had mentioned. So Buspar, it's a very mild anti-anxiety agent. It works really well for some kids that have generalized anxiety disorder. It works well for some kids that have a neurodevelopmental disorder with a lot of anxiety. has a really good side effect profile. You can titrate up from starting at maybe 10 milligrams twice a day up to as much as 60 milligrams. Some people think it's a placebo. It doesn't really have that much of an effect. But for people with anxiety, they say it does make a difference without a lot of other side effects. And then anxiolytics like alprazolam and clonazepam are things that, as I alluded to earlier, we use for short periods of time, like a kid that's really anxious or has had a really traumatic event, or a kid that really has a hard time going to the dentist or flying on a plane. But if we use, as you all know, if we use them too often, they begin to lose their effectiveness. And then we're tempted to keep going up on the dose because the parents want to keep going up on the dose. And then they become hard to get off of. So we use them cautiously. I have some kids that just don't do well on anything but, and I usually stop at the max of 1 milligram twice a day for some of my kids on the autism spectrum, but I use them real cautiously and don't like to keep at it. Propranolol helps with anxiety. You might know of people using it for performance anxiety, musicians, speakers, but kids at exam time can find propranolol helpful as well. And for sleep, hydroxyzine can be helpful, and it can be helpful with anxiety as well. But I use it kind of like Benadryl, but it's not as drying as Benadryl is, to help kids with sleep, and it doesn't seem to wear off like sometimes Benadryl does. So those are my other categories, and I'm not going to talk more about those today. Next slide, please. I know I can't see you. If I had an audience, I'd say to you, how's the pace? I know I'm going fast. Is it too fast? Is it too slow? You want me to speed up? You want me to slow down? And I don't have a way that I can see your thumbs up or thumbs down, but you can put something in the chat if you say you're just going too fast. I'm having a hard time keeping up. But thank you. Somebody said the pace is good, and I'm going to keep it up so we get through this. So the first thought that you have is, what kind of medication could I use? The second thought is, what's the symptom that I'm trying to treat? What's the primary symptom? And it's usually more than one, or often more than one. But if you say, what's the main thing that's most distressing right now? And you could say it's distractible inattention. So, or you could say it's impulsivity, or any of those things listed up there. And on the next slide, it says, where does that lead you? So it would say distractible inattention improves with stimulants. So you're thinking about, okay, this person's really distractible. Maybe they're impulsive too, but I might be thinking about a stimulant. Impulsivity and depression, we talked about that some. We might start with an SSRI, but move to maybe other antidepressants. Affective instability improves with mood stabilizers, lithium, valproic acid. Cognitive disorganization, someone that is not tracking well, somebody that might be delusional, hallucinating, have extreme anxiety, then might be considering atypical neuroleptics. And hyperarousal, a kid that's just very anxious, improves with alpha adrenergic agonists and with beta blockers sometimes. So next. So distractible inattention, what do we mean by that? These kids have unsustained attention. They don't listen. They don't follow through. They're disorganized. They avoid mental effort. They're easily distracted. You try and give them 2 or 3 commands. They can get through one. I ask parents often, and I say, if you ask him to go into the kitchen, empty the trash, get you a glass of water, and shut the door to the basement, can he do all 3 of those, or does he get one done and then he's all through? Or another example that I give to them even is like a kid in watching television, and dinner gets ready and mom or dad calls him and says, Johnny, come on into dinner. And he looks, and then he gets up, but on the way to the kitchen, he looks out the window and he sees his friend and he starts trying to interact with him, or he sees his Game Boy and he starts playing with that. He never makes it to sit down to have dinner. You have to somehow almost get him to do that. But then you finally go in and you say to the kid, come in to dinner, but he doesn't look at you. He doesn't pay attention to you. And then you grab him by his chin and pull him and say, come into dinner. And he shakes, he says, oh, okay. And he comes to dinner. Well, that's not distractible attention. That's more over-focused attention. And you might be thinking of something more like OCD or another kind of difficulty than somebody who you might say has difficulty paying attention, but the difficulty is they can't shift focus. And the person with ADHD is shifting focus all the time. They're just moving from thing to thing to thing. And it makes it hard for them to interact with others because they don't look at people's faces long enough to read their emotions. They, as a spouse, are sometimes difficult because a spouse will come, the other side of that will come in and say, well, I start talking to him and he's off thinking about something else, or he doesn't pay attention to me. And that can often lead to marital difficulties for adults, but it can often lead for kids not getting along with their peers because they can't stay focused enough to read those emotions well. Next slide. We're thinking then of using stimulants. And you remember we started talking about the methylphenidate family, and there's Ritalin. The regular acting Ritalin lasts about 3 to 4 hours. You'll see in the slide after this from the American Academy of Pediatrics, which I thought would be relevant to you all, but it says 6 to 8, not in my experience, or 4 to 6. It's usually 3 to 4. The extended release methylphenidate, like Concerta, lasts about 10 to 12 hours. Methylphenidate, like Methylene, Metadate, the methylphenidate like Ritalin, LA, those are more like 6 to 8 hours. The Focalin has an XR and it lasts 10 to 12. The short is more like 6. The Dexedrine, regular Dexedrine, you'll see on the next slide that it says 4 to 6. I think it's 3 to 4. The amphetamine mixed salts like the Adderall, and Adderall is more like 6, and Adderall XR is 10 to 12. Vyvanse is 10 to 12. And then Daytrana, Quilivant, Neptenso, or other forms, and we'll talk about those in just a few minutes. Another nice review, if you're interested in stimulants, is the one at the end of that slide that's from 2020, and I think it was in the New England Journal of Medicine, so a nice review. Next slide. Goes through the length of time, and again, as I say, it came from the AAP, but I think they're a little generous in the duration, at least in my experience. It's a little shorter than that. And so when young people come in and tell me, no, it wore off after 10 hours, and they're talking about the Adderall XR, the Vyvanse, I don't disagree with them. I say, maybe, well, we need to consider other strategies then about how to get you through the rest of the day. And we'll talk about that. Next slide. If we look at the effectiveness at each of these, and my response rate graphic or bar somehow came off, and what those methylphenidate and amphetamine are is at about 80%. The tricyclic antidepressants, which is what Adderall and this new one that we just talked about, they tend to be more like 7 to 8 hours. Wellbutrin, or about effectiveness, I'm sorry, is about 70%. Wellbutrin's about 60. Even MAO inhibitors have been found to be effective about 60, clonidine, guanfacine about 60. So you can see stimulants are by far the best. And on the next slide, we'll see that we can look at somewhat equal efficacy, although some people think maybe dextroamphetamine is a little better for distractible inattention, and methylphenidate has a little better side effect profile. But would say that 70 to 80% respond to one. And if you try both, then it goes as high as 90 when you try both. So it says they're not the same. It says it's worth trying one and then try the other before you jump out and give up. They've done surveys of who prescribes which kind of medications. And child psychiatrists tend to prescribe more dextroamphetamine, and primary care physicians tend to prescribe more methylphenidate. And that may be because people start with methylphenidate because they think the side effect profile is a little better. But then after they've tried one, they say, oh, I'm sending him to the child psychiatrist. The child psychiatrist then says, okay, they've tried methylphenidate. Now I'm going to try dextroamphetamine. And it could be, if you felt comfortable in this field, you could try both of those. And then if neither worked, then you try the child psychiatrist, or the child psychiatrist might go on, especially if there are side effects, to considering some of those alternatives that we talked about, like atomoxetine. And some seem to do better with one stimulant or the other, and it's worth trying. Next slide, please. So the MTA, the multimodal treatment study, was the one that really kind of set the standard for kids that were pediatrics, aged kids, looking at stimulant medication. And it started a number of years ago, but they keep following these kids up now, even into adulthood, to see how they're doing. It was a multi-site trial. But they found that medication management was as effective as medication management plus behavioral treatment. So everybody looked at that and said, oh, we don't need to do therapy. We don't need to do behavioral treatment. Just give them the med, that's all they need. And then as they studied them longer, they really found that things like anxiety and multiple comorbidities did better if you had both. It's pure ADHD, and you don't see that many people with pure ADHD. So you may say, okay, that you tried a stimulant that works well, maybe, and they're doing better. Maybe they don't need therapy. Maybe they don't need the other things. But usually there are some other things like impulsivity and others that could benefit from a good behavioral treatment program that could be part of it. It might be CBT, it might be more behavioral, but adding those together seems to have a better outcome long-term than if you use just medication alone. Next slide, please. Adverse effects, I think you're all familiar with these, and if you just keep going through them all till we get them up. Decreased appetite. So then you try to find other times to feed. So when you're on that downhill slope, then you eat, or you eat at breakfast. There are some kids that I just can't keep weight on, and I use things like Sustacal or Metrical that they can go to the pharmacy and buy over the counter and loses away. Or sometimes it wears off later at night, and so the family mealtime may change from late afternoon or early evening to mid-evening, or they may have a big snack at night that's you hope is healthy, but maybe you hope they have healthy meal the rest of the time, and maybe it's more of a high calorie thing. Growth suppression is controversial. Some studies say there's not growth suppression. Some studies say there is. Some people say there is, but it's very small, very tiny. And that growth hormone tends to have while it might have a smooth course, if you weren't taking stimulants, there is a way that it suppresses, rebounds, suppresses, rebounds. And so sometimes people think of drug holidays as being something that can help. But the studies long-term say ADHD may suppress growth, but the stimulants, not as much. Insomnia, sometimes that can be due to rebound. The medication wears off and they were focused in, and now all of a sudden everything is wide open. So considering an afternoon dose of a short acting could help them study at night and maybe fall asleep, or considering something like melatonin or something mild to help them through that rebound period. Tics, people at first, and I think with some justification, said maybe stimulants cause tics. Most of the studies say stimulants might precipitate tics, but it's not like they're that they were not underlying to begin with. It's more like you brought them out and they happened. And then rebound effects. Medication wears off, the kid does even worse. And so the kid comes home from school, they had a good day at school, but they're rebounding and they're into everything. And so for parents to say, why don't you go out for a walk? Or what about jumping on the trampoline for a little while? Or maybe we could have a snack right now, or find some distractor to help them through that period. Next slide. And then others that you know about as well, and rarely psychosis. So I know I'm taking a little too long, so I'm going to do this last slide on stimulants and then move on to something else. There was an interesting article in JAMA and just a few months ago, a month or 6 weeks ago, saying they looked at a number of preschool age children and found that actually did a little better on alpha adrenergic agonists than they did on stimulants. The adverse effects with stimulants was greater, whereas the adrenergic agonists were a little more likely to result in sedation. So the stimulants with moodiness, appetite suppression, and difficulty sleeping seemed to not be as good for these younger preschool kids as considering alpha adrenergic agonists. Next slide. And I'm going to skip that to talk about, I'll hit a couple. Extended release formulations may enhance compliance. There's some liquid chewable topical forms that were on my list. You saw like the patch, the Daytrana patch, and the Quillivant that comes both in a chewable form and in a liquid form. Or you can take Vyvanse and you can mix it in water and stir it up, and they can swallow that if they're having trouble taking it because they don't swallow pills. Next slide, please. So I just went through those, Daytrana, Vyvanse, the others. And when we think about non-stimulants, some parents just don't like the idea of a controlled substance. Some kids just don't adequately respond to or tolerate a stimulant. They don't like the side effect profile. And so then we're into thinking about atomoxetine on the next slide, that it works more on the noradrenergic system, as I said. There may even be some improvement in anxiety and depression if it's present from atomoxetine. It improves social and family functioning. We probably started off using too low a doses because now they're saying we can go as high as 100 milligrams once a day. Next slide. Adverse effects, it can decrease appetite, but not as much as stimulants. Can cause the side effects that you're seeing up there. It may also affect height and weight with longer term treatment. There's not a way of saying that it does, but it's a potential. And it can cause liver toxicity in a small percentage of kids. And suicidal thoughts as antidepressants carry this black box warning that is controversial, but atomoxetine, because it's an antidepressant, carries the black box warning as well. Next slide. Wellbutrin, we talked about a little bit, saying maybe 60% improvement. It may help also with ADHD and with conduct disorder and substance abuse. For kids that might be smokers in adolescence, it may help them stop smoking in addition to treating their ADHD. Stimulant non-responders may respond, so it's worth another try. And the concern is, especially with the immediate release, is that if they have a seizure disorder or an underlying seizure disorder, it needs to be used with caution or maybe not at all. And the longer acting doesn't have as much of the seizure concern, but I found some neurologists say, keep on if you think it's helping and we'll control the seizures. I've had other neurologists say, please stop the Wellbutrin, that's not helping me get seizure control. So you can find both. Next slide. There are a variety of unproven treatments, EEG biofeedback training. The verdict isn't in, and unproven doesn't mean it doesn't work. It just means we don't have a definitive study to say what happens. Same with dietary manipulation. Some studies say it does help, some not. Megavitamins, some it does, some it doesn't. Herbal treatments, manipulation, sensory integrative training, anti-yeast supplements. When parents come in and they're interested in trying them, I say, okay, if you want to try them, find somebody that knows what they're doing and give it a try, but let's make an appointment in 3 months and check in and see how it's working. And then maybe we can talk about these other medications again. Next slide. I'm going to skip this one. Impulsivity, the difficulty with response inhibition. You need to think about overstimulation, practicing and encouraging delay. And SSRIs can increase serotonin, adrenergic blockers can reduce norepinephrine, neuroleptics to reduce overstimulation can all be strategies to think about that. You may start just with an SSRI and then think about a child psychiatrist. Next. On the one side for distractibility, and this distractibility impulsivity tree, we can think about methylphenidate and dextroamphetamine. For the impulsivity side of the equation, SSRIs. For both, that kind of in the middle, thinking about bupropion, clonidine, tricyclics, and then different combinations, things like mood stabilizers. Next. Antidepressants. I won't spend long here because we talked about it already. We said, generally, the literature supports that we should start with SSRIs, and the ones that we most frequently use are fluoxetine, sertraline, and citalopram. There are others on the left side until you get to duloxetine, and then you go down through noradrenergics until we get to bupropion. Then we're talking about dopaminergics, and then the others that are there we use very infrequently and probably are not something that you're using regularly in your practice. So I wouldn't go there. If they didn't respond, then I'd try and find a good antidepressant type psychiatrist and see if they can help. Next. Anxious hyperarousal. These kids are just kind of overstimulated. They may be hypersensitive to loud noises, to smells, to a bunch of things. What can you do to help with that anxious hyperarousal? They may have poor integration too of their sensory kinds of stimuli. And they may have an autonomic overreactivity. They have things like an increased startle. You may find that they just really jump out of their skin. Next. So we're thinking in this group, as we talked before, of clonidine, guanfacine as alpha adrenergics, and then propranolol as a beta blocker. And they're the best responders, these overactive, uninhibited, impulsive kids. Increases frustration tolerance. Effect size for working for distractible inattention is less than with stimulants, but it can still help with ADHD. Next slide. The guanfacine has the most evidence in the literature, but not a lot. There was a recent review done in 2020, but most of the things that are reviewed were studies that were done from a while ago, and mostly done looking at either at kids with ADHD or some with kids on the autism spectrum. And they can be combined to try and get both an effect on distractible inattention and on impulsivity, or they can be used just alone if the stimulants, either parents don't want to use a controlled substance, or stimulants had side effects that we're just not able to get around. So then one might consider trying guanfacine, which does have an indication for ADHD. And it may help too with comorbid tics. So you can put those two together. Next. Affective instability. We talked about that. Mood lability, rages, euphoria, rapid cycling, activation. We're going to talk at the end, or if we have time, I have a slide on what's called disruptive mood dysregulation disorder, which has been getting increasing attention from a group at NIH that studied bipolar in kids a lot, but they found these kids were kind of like bipolar, but they weren't classic bipolar, but they had affective instability and they had a lot of disruptive mood. And they also did well on mood stabilizers. So it's not just for bipolar. So the next slide. Mood stabilizers, we talked about already. The most common that we use are lithium and valproate. Occasionally, I'll use gabapentin, topiramate, pregabalin. You have to be worried on topiramate to not go high on the dose. I found some neurologists do, and then the kids get squirrely. And when I used to live in New Jersey, there was this wise neurologist that told me, never go above 75 milligrams with topiramate. That makes these kids squirrely. And so I'd be cautious with that, or if you see somebody on that higher dose, wonder about it. But it helps with weight gain and it may help with mood stabilization. Next. Cognitive disorganization, executive function deficits, meltdowns, thought disorder. Next. We went through those different kinds of atypicals. The ones we use primarily with kids are risperidone, aripiprazole, and quetiapine, although when we're concerned about weight gain, we may think of trying geodone. There's concerns about cardiac arrhythmias in adults. Some people would suggest we might even get EKGs with kids, but they always recommend it with adults. Lurisidone, Latuda may not have weight gain, but it has this inner restlessness. Acenapine, all the other, Brexpiprazole has just come out. We have a study going on for that right now. If any of you want to refer somebody into Brexpiprazole, which is related somewhat to aripiprazole, but maybe has less side effects. Olanzapine works well, but has a lot of weight gain. So you can see our favorites. Next. There have been studies of risperidone. They were done a while ago, and they looked at kids with low IQ was the first ones that came out, then saw improvement in aggression, mania, and psychosis, and also in conduct disorder. Those are the early ones that led people into using more and more of it. The next slide, I think, talks about using risperidone in autism that led to the FDA giving an approval for treating irritability. And shortly after Risperdal got it, then next slide, aripiprazole got it, got an approval again as well for having enough kids and more than one study that led to approval for using it to treat irritability and autism. It made people feel more like using it even for other kids, but it's not indicated for conduct disorder. It's not indicated for depression, but it's indicated for this kind of poorly organized, disorganized, unglued, unput together kind of kid that maybe isn't stuck with just a diagnosis of autism, but may have other things related to it. But as you know, we use it with caution because it causes weight gain. Rarely it can cause tardive dyskinesia, really rarely. The weight gain and the other kinds of cholesterol, type 2 diabetes, others seems to be lifetime dose dependent, but can still happen to kids pretty fast. So it's worth always checking fasting glucose, cholesterol, triglycerides at least once a year to know that that's not becoming a problem, especially in those that gain weight. Next slide. So uncommon adverse side effects include being activated, insomnia, hypotension, hepatotoxicity, withdrawal dyskinesias when you're coming off. The Risperdal causes changes in prolactin, so you can have galactorrhea. You can also have boys getting breasts, and it can sometimes cause enuresis. And I think I'm going to do these next two slides, and then I think I'll have about 3 minutes for anybody's comments or questions after my zooming through this so quickly. So, Years ago, people would say, God, isn't it awful the way some people are using more than one medication now? It's like, they put all these things together, and how do they even know what's happening? I think now we find a lot of kids are on more than one medication, and it's because they have more than one of those symptoms that I was talking about. So you're looking at multiple target symptoms, you're looking at different medications, mechanisms of actions. You're hoping these drugs can work together, like maybe a stimulant and an alpha-adrenergic agonist. But you have to worry about drug interactions. Why do you put them together? And if you see something not going well, is it because of their disorder, or is it because these two medications aren't doing well? Next slide in my last, is that it's important to identify and monitor those target symptoms, know what you're looking at. It's important to maximize one dose before adding or discontinuing another. I find sometimes when I'm asked to do a consult, somebody's been going up on one and up on another, up on the other, up and up and up and up. And it's hard to know what's really working. And it's important to change and adjust one drug at a time. When parents come in and they're distraught, you'll say, okay, let's up all three of them. You need to be monitoring side effects and then discontinue the drug of least benefit. So what I think I had after this were some cases that we could discuss. This was the DMDD, and I'll leave it on this as we see if there's any quick. I see 11 chats, and Joan's supposed to help me figure out which one of those I should answer.
I'm going to start with those that actually came into the Q&A chat.
Okay.
One is, do you recommend routine EKG before starting a stimulant if there's a family history of cardiac disease?
If there's a family history of cardiac disease, and then I consider it. If the kid has a history of cardiac disease, then I do, and I ask for a consult with a cardiologist. There is a report both from the American Heart Association and from the the American Academy of Cardiology that said they didn't worry about stimulants and heart problems. There was concern for a while, but if the kid has cardiac abnormalities, or if the first time I try one, they get a tachycardia or an arrhythmia, then I always do.
So thank you. And is it okay to open an Adderall XR capsule and mix it with food? And how about other XR capsules?
The Adderall XR capsules don't do well when you open them and mix them on food. They have 4 different kinds of dexedrine salts, and so you don't know which one you're eating at the time when you do it. You can do it with Vyvanse. You can do it with actually Ritalin long-acting. That's okay. You can't open a capsule of Concerta, and it's not advised for doing it with Focalin either.
Okay, wonderful. And how do you navigate the need for a second or third medication with a family who's hesitant to start one to begin with?
I think that's hard. I usually try and go slow with families that are concerned. I may even start off, suggesting they look at diet and they try and eliminate all the sugar that they can, and that they think about some of those things, and then start slowly with a stimulant medication. And if they seem to do better, but there's still room for improvement, or if they have side effects, then I talk about these different mechanisms of actions and are trying to get a benefit from each. And I usually find if I've gotten a good result, but with side effects on the first go round, they trust me to go on to more.
Okay, wonderful. And the last question here, the first one that came in was, is there a role for genetic testing for choosing medication?
So there are 3 now, I think, genetic tests that are out there now that have to do with medication. They don't tell you what medication to choose. They tell you what medication might have side effects, because they look at the enzymes that break down the particular drug that we're using. So people who don't read the fine print or don't think about it, and especially your patients or the families, will say, oh yeah, there's a test that'll tell you which drug to use. They'll say, no, it tells me which one I'm going to have side effects with. I don't usually use that first time around, but I tell parents about it, and if they'd like to and say, I'd like that to help me choose the first time, then I'll do that. But sometimes if their insurance doesn't pay for it, can cost up to $300. So I usually say on the second, though, if we've had a side effect, well, let's try the Genamind or Sept, or let's try one of these others. And I think it has a place then. A lot of psychiatrists still don't, but I find that it's helpful in thinking they're lacking an enzyme to metabolize an SSRI, so I'm just not going to use an SSRI, I'll try something else. It helps with decision making.
Fantastic. And we are at time. Thank you so much, Dr. Hendren,
Sure.
for this wonderful talk today. Thank you all for attending. Please take a moment to scan this QR code in order to check in and get credit for today's activity. And we'll see you next month, Thursday, October 14th, around noon. And this is on developmental processes in youth mental health.